If you break your arm, the X-ray shows exactly where the bone snapped. It's binary, right?
Right, yeah, you see the jagged white line and you know exactly what the problem is.
Exactly. It's almost comforting. You point to it, the doctor points to it, and you instantly know it needs to be fixed. But right now, over 50% of postmenopausal women are suffering from a condition that has no clean X-ray.
Yeah, there's no visible cast for this.
No, not at all. And it's a condition so heavily stigmatized and just rarely talked about that the British Menopause Society literally calls it a silent epidemic.
And because it's silent, people just suffer alone. They
Yeah.
assume it's just an inevitable part of getting older.
Which is exactly why we're diving straight into it today. Welcome to the deep dive. We're looking at women's intimate health as they age, specifically focusing on vaginal dryness and painful sex.
It's a heavy topic, but so important.
So important. And we're tackling one very specific, highly debated question for you today. Can a buzzy sort of futuristic treatment known as the O-shot,
Oh yeah, the O-shot.
right, which involves injecting your own blood plasma into your most sensitive areas, can that actually cure vaginal dryness?
I mean, it sounds a bit like science fiction, or maybe a trendy vampire facial just taken to the absolute extreme.
It really does.
But it is very much a reality in, like, thousands of clinics right now.
Yeah.
Platelet-rich plasma therapy, or PRP, is just booming.
It's literally everywhere. And to figure out if it actually works, we've pulled together a massive stack of sources for you. We've got rigorous soaping reviews analyzing dozens of peer-reviewed studies. We're also tracking this fascinating ongoing double-blind clinical trial. It's specifically NCT 073 or 6611 for anyone who wants to look up the primary literature themselves.
Which I highly recommend doing.
Definitely. And we're cross-referencing all that hard science with medical guidelines and, well, the actual very glossy marketing brochures from aesthetic clinics that offer this procedure.
Yeah, you really have to look at all those angles because the gap between what a commercial clinic promises you on a flyer and what a peer-reviewed medical review actually confirms, I mean, those can be wildly different things.
Oh, absolutely. But I think before we even look at, spinning blood in a centrifuge, we really need to understand what's going wrong at a cellular level first.
That's the best place to start.
Because the sources emphasize that vaginal dryness is not just, needing a little extra lubrication. It's often the primary symptom of a chronic progressive condition called genitourinary syndrome of menopause, or GSM.
Yeah, the older medical terminology for this was vulvovaginal atrophy, or VVA.
Okay.
But the terminology shifted to GSM recently to capture the fact that it's a really broad syndrome. It affects the vulva, the vagina, and the lower urinary tract all at once.
So what is actually happening in the body to cause this whole syndrome?
It's driven entirely by a drop in estrogen.
Just that one hormone.
Pretty much. Think of estrogen as this constant humming chemical signal in the background. It tells your vaginal and urinary tissues to hold on to moisture, to maintain their elasticity, and to produce collagen.
Okay, so it's giving the maintenance orders.
Exactly. And when that signal goes quiet during menopause, the tissue literally forgets how to maintain its own structure.
Wow. The machinery just powers down.
Essentially, yes. The tissue thins out dramatically, the natural lubrication mechanisms just shut down. And this leads to something called dyspareunia, which is the formal medical term for painful sex.
And reading through the sources, I mean, the emotional and psychological toll of this is just staggering.
It's heartbreaking.
We are talking about women experiencing a severe loss of confidence, massive relationship strain, and this pervasive feeling of being completely disconnected from their own bodies. But because of the stigma, they don't tell their doctors, they just endure it.
And that silence actively compounds the physical symptoms. Because women are, reluctant to discuss the pain, the condition goes underdiagnosed and undertreated.
Which just makes it worse.
Right, it allows the tissue to deteriorate even further. The longer the estrogen signal is gone, the more the tissue atrophies.
Wait, okay, hold on. If the entire root cause of this is just a lack of estrogen, aren't we kind of overcomplicating this?
How so?
Like, why are we talking about injecting blood when a standard estrogen cream should just replace the missing hormone directly?
That is honestly the most logical question to ask. And for a large portion of the population, topical, low-dose estrogen is the gold standard treatment.
Right, because it works.
It's highly effective. It thickens the epithelium, which is the surface layer of cells lining the vaginal wall. It improves local blood flow, and it increases mucus secretion.
So it sounds like it solves the problem perfectly.
It does, for many.
Yeah.
But standard estrogen therapy simply does not work for everyone. First off, there's a significant subset of women who only have an incomplete response to the creams.
Meaning what, exactly?
Meaning their tissue has become so severely atrophied over the years that topical estrogen alone isn't enough to fully restore its function.
Oh, I see. The tissue is so damaged it can't even respond to the signal anymore.
Exactly. It's just too far gone for a simple topical fix. And then we have a massive population of women who have strict medical contraindications to estrogen.
Like who?
Breast cancer survivors are a primary example. For many of them, introducing exogenous hormones into their bodies, even locally, carries risks of cancer recurrence that their oncologists simply will not accept.
Wow. Okay, yeah, that makes total sense.
And finally, some women just strongly prefer non-hormonal options, due to personal comfort levels or fear of other side effects.
So if half the population goes through menopause and a huge chunk of them either can't or just don't want to use estrogen, you have this massive unmet demand.
A total vacuum in women's healthcare. And that vacuum is currently being aggressively filled by regenerative therapies, which is exactly where platelet-rich plasma enters the chat.
Okay, let's get into the mechanics of the O-shot then, because the idea of a needle in that specific area sounds deeply intimidating.
Oh, totally terrifying for most people.
Yeah. So what is this vampire science actually doing?
The procedure itself is surprisingly straightforward, really. It starts with a simple blood draw from your arm, just like you get at a routine physical.
Okay.
That vial of blood is then placed into a centrifuge, which is a machine that spins the blood at incredibly high speeds.
And the goal of spinning it is to separate all the different components of the blood based on their weight, right?
Yes, exactly. The centrifugal force pushes the heavy red blood cells to the bottom, and we don't want those for this procedure. What we want is the plasma, the liquid part of the blood, and specifically, we want to isolate and concentrate the platelets within that plasma.
Platelets, those are like the body's natural first responders.
Precisely. Whenever you get a paper cut or, scrape your knee, platelets are the tiny cells that rush to the site. They clot the blood to stop the bleeding. But more importantly, they act as the chemical messengers that signal the rest of the body to start repairing the damaged tissue.
Okay, so the doctor extracts this platelet-rich plasma, this sort of golden liquid, applies a topical numbing cream to the patient, and then injects that concentrated plasma directly into the targeted areas of the vulva and the vagina.
That's the procedure. But the real magic happens at the cellular level after the injection.
Right, because the sources keep talking about an alphabet soup of growth factors that these platelets release. I know they clot blood, but how do they suddenly become, like, tissue builders?
Well, when the concentrated platelets are injected into the tissue, they release a massive payload of growth factors. The sources highlight three main ones.
Let's hear them.
You've got VEGF, which is the body's signal to build brand new blood vessels. You have PBGF, which promotes cell division and growth. And TGF-beta, which modulates inflammation and basically guides the whole tissue repair process.
Okay, let me make sure I'm wrapping my head around this. If topical estrogen is like watering a dry garden, trying to revive the plants that are already there, the O-shot is like extracting a highly concentrated organic superfertilizer from your own backyard and injecting it directly into the soil to force entirely new roots to grow.
I love that. That analogy perfectly captures the mechanism. This fertilizer doesn't just wet the tissue, it structurally changes it. The growth factors literally activate pluripotent stem cells in the area.
Pluripotent stem cells, those are basically the body's blank slate cells, right? The ones that can turn into whatever specific tissue the body needs in that exact moment.
Yes. The growth factors wake up those blank slate cells and tell them to get to work. Because you're stimulating the creation of new blood vessels, you are bringing significantly more blood flow to the area.
And blood flow is everything here.
It really is. Blood flow is what causes the tissue to plump up naturally, and it is the primary engine that drives natural lubrication during arousal.
And it goes beyond just blood flow, right? The sources mention that it also targets fibroblasts and nerves.
It does. It forces a proliferation of fibroblasts, which are the specialized cells that manufacture collagen and elastin.
Oh, nice.
Right. That is what restores the physical thickness, the stretch, and the elasticity of the vaginal walls. It's actively reversing the thinning caused by that drop in estrogen we talked about.
That's incredible.
And crucially for treating painful sex, these growth factors support nerve regeneration. They help repair and grow sensory nerve endings that might have deteriorated over time.
So the end result of this microscopic construction site is deep tissue hydration, increased natural mucus secretion, and smoother, thicker, more sensitive tissue.
That's the goal.
I mean, if the cellular science is that promising, you'd think this would just be a standard prescription covered by every single insurance plan. But, and this is a big but, when we look at the clinic brochures in our stack of sources, it feels less like medicine and more like a late-night infomercial.
Oh, the marketing from aesthetic and wellness clinics is undeniably aggressive, and it often runs far ahead of what the rigorous scientific data can actually support.
I mean, let's look at what these clinics are actually promising. They advertise that the procedure takes less than an hour. They say it involves only a mild pinch because of the numbing cream. There is zero downtime. They literally claim you can go back to work immediately or even have sex that same day.
The convenience is certainly a major selling point for them, but it's the list of treatable conditions that really requires scrutiny.
That's the part that feels totally wild to me. The brochures claim the O-shot treats vaginal dryness, low libido, inability to orgasm, painful sex, severe skin conditions like lichen sclerosis, and even urinary incontinence.
It's quite a list.
It's a massive list. They boast an 80% success rate and say results last anywhere from 12 months to 2 full years.
What is the actual reality check here? Are we just looking at a heavily marketed placebo?
To find the reality, we really have to bypass those glossy flyers entirely and look at the scoping review included in our sources.
The one analyzing 43 different studies. Yes, it analyzed 43 independent studies, including randomized controlled trials and cohort studies, looking specifically at PRP in gynecology. We also have to weigh the official guidance from major medical bodies like the Royal College of Obstetricians and Gynecologists, the NHS, and the MHRA.
Okay, so let's separate the facts from the fiction. What does the hard data actually support? Let's start with the good news.
The good news is that PRP is not snake oil. The biology we discussed, the superfertilizer effect, it actually holds up in the clinical data for certain specific conditions.
Okay, good.
The review found that PRP does show genuine, measurable promise for improving symptoms and quality of life for vulvar lichen sclerosis, which is a very painful, chronic inflammatory skin condition.
And does it hold up for our main question today? Like, does it actually help with vaginal dryness and the pain associated with it?
It does. The studies show genuine promise for treating sexual dysfunction linked directly to dryness and poor nerve health. Because PRP structurally regenerates the tissue and increases that vascular network, women are reporting statistically significant improvements in natural lubrication and physical sensitivity.
Wow.
The tissue quality is measurably better.
So the new roots are actually growing, but where does the marketing overstep the science?
The evidence really starts to fall apart when we look at the claims regarding vaginal laxity, meaning muscle tone, and stress urinary incontinence.
Which is fascinating because almost every single clinic website we looked at prominently featured incontinence as a primary reason to get the O-shot.
I know. But the clinical reality is that the evidence for treating incontinence with PRP is currently inconclusive at best. Major medical bodies strongly advise caution here.
Why is that?
Well, PRP is fantastic at regenerating mucosa, skin lining, and blood vessels. But urinary incontinence is very often a structural mechanical issue involving weakened pelvic floor muscles and supporting ligaments.
So injecting plasma into the surface of the vaginal wall isn't going to somehow tighten a weakened pelvic floor muscle.
No, it's not.
It's like trying to fix a sagging suspension bridge by just repainting the road.
That is a perfect way to put it. The paint might look great, but the bridge is still structurally compromised. And that brings us to the other major caveat we have to discuss, the word investigational.
Right.
Despite the booming clinic industry, the broader medical community still officially considers PRP for sexual sensitivity to be an investigational treatment.
Wait, why is that? If the scoping reviews show it physically improves tissue and lubrication, why isn't it just the standard of care?
A massive hurdle right now is what researchers call heterogeneity across the studies.
Meaning there's no consistency in how it's done.
Exactly. There is zero standardization. One clinic might draw a large amount of blood and spin it in a specific brand of centrifuge for 10 minutes. Another clinic across town might draw half that amount and spin it twice at a totally different speed.
Oh, wow.
Right. So the concentration of platelets, the actual dose of the medicine you are receiving, can vary wildly depending on the specific equipment the clinic bought and your own unique biology on that given day.
So when a clinic claims an 80% success rate, you literally have no idea what concentration of PRP they are actually using to get that number.
You don't, and neither do the scientists. Because there is no universal FDA-approved dosage protocol for this yet, it makes it incredibly difficult for researchers to compare studies side by side and say definitively, yes, protocol X yields result Y every single time.
Okay, so where does this leave you, the listener? Let's say you are dealing with the frustrating, silent, painful reality of vaginal dryness. You've tried the over-the-counter moisturizers, maybe estrogen isn't an option for you, and you are seriously considering walking into a clinic for the O shot. What do you need to know about safety and the ultimate proof that this works?
On the safety front, the data provides genuine reassurance. The safety profile of PRP is excellent.
Because it's literally just your own blood.
Precisely. It is an autologous treatment, meaning it is derived entirely from your own body. Therefore, the risk of an allergic reaction or your body somehow rejecting the plasma as a foreign substance is practically zero.
You aren't introducing synthetic fillers or animal-derived products.
Exactly.
And the side effects mentioned in the sources seem pretty mild, right?
They are very minor and temporary. Patients report some local swelling, a bit of bruising or discomfort at the injection site that resolves in a few days. The risk of major complications is incredibly low.
Okay, so we know it's safe. But to truly settle the debate on whether it's effective for dryness without relying on, subjective clinic surveys, the scientific community is stepping up the rigor. Let's talk about that ongoing clinical trial we found in the sources, NCT 073066111.
This trial is so important because it is a double-blind, placebo-controlled study that is the gold standard of medical research.
I was reading the methodology for this, and it is intense. Half the patients in the study are receiving the actual PRP injections, and the other half are receiving a placebo injection of normal saline solution. And they are tracked over 6 months.
Which requires immense dedication from those volunteers, undergoing a series of injections in a highly sensitive, intimate area, knowing you might just be getting salt water. It's a profound commitment to advancing women's health science.
It's the ultimate BS test for those glossy clinic brochures. But how do they filter out the placebo effect? Like, are they just asking the women how they feel on a scale of 1 to 10?
No, and that's the beauty of this trial. They aren't just relying on subjective questionnaires. They are using objective, physical measurements to assess the tissue.
How do you even do that?
They use specialized tools to measure the actual physical elasticity, the firmness, the structural thickness, and the moisture content of the vaginal wall.
Wow. They are sending instruments in to literally measure the strength and hydration of the new roots.
Exactly. Real, rigorous science is actively working to validate these regenerative claims with hard data. We don't have the final results of that specific trial yet, but the fact that it's happening means we are moving from the Wild West of aesthetic marketing into serious medical validation.
So pending those final gold standard results, who should actually be booking this procedure right now?
Well, if we synthesize everything from the biology to the clinical guidelines, the ideal candidate is someone who understands that the O-shot is not a magic overnight cure-all. If your primary issue is a hormone deficiency, and hormones are a safe and viable option for you, PRP does not replace systemic or local estrogen.
Right. Going back to our garden analogy, if your soil is dry because someone turned off the water main, the super fertilizer is great, but you still need to turn the water back on if you possibly can.
Perfectly said. However, the O-shot is an incredibly promising tool for specific groups. For postmenopausal women who cannot take hormones due to cancer risks, for postpartum women dealing with severe tissue trauma from childbirth, or for women on medications like SSRIs.
Oh, let's clarify that real quick. SSRIs are a common class of antidepressants, right?
Yes, and while they're life-saving for mental health, they frequently cause severe sexual side effects, including numbing of the sensory nerves and extreme vaginal dryness.
Oh, I see.
For those women, trying to wake those nerves back up with a regenerative therapy like PRP is a very logical approach. The O-shot belongs in a broader regenerative medicine toolkit, ideally used alongside things like pelvic floor physiotherapy to address the structural issues.
It gives you options. And I think that brings us to our final takeaways for today. We started this deep dive talking about a silent epidemic, vaginal dryness, and the profound physical and emotional pain that comes with it should not just be accepted as your new normal.
It is not just a standard consequence of aging that you have to suffer through quietly. The science has advanced far beyond telling women to just deal with it.
While the standardized clinical data might still be playing catch-up to the slick aesthetic marketing, the underlying biology is very real. The O-shot utilizes your body's own growth factors to stimulate actual tissue hydration, build new blood vessels, and repair nerves.
And the most important takeaway is to advocate for your intimate health. If you are struggling, break the silence. Talk to your doctor. Ask about topical hormones. Ask about pelvic floor therapy. And yes, ask if regenerative options like PRP make sense for your specific biology.
You do not have to navigate that murky diagnostic landscape alone.
And as we wrap up, I want to leave you with a broader thought to ponder. If we step back and look at the trajectory of medicine, if we are reaching a point where we can successfully draw our own blood, spin it down, and use it to literally regenerate our most intimate, delicate, aging tissues,
Yeah.
what does this mean for the future of medicine as a whole?
Oh, wow. Are we entering an era where our own bodies become our most powerful, personalized medicine?
Exactly. It challenges the entire pharmaceutical model.
Yeah.
Could treatments derived from our own cells eventually render broad synthetic drugs a thing of the past?
It's an incredible prospect. We started this deep dive by comparing medical diagnoses to X-rays, looking for that clean, jagged white line of a broken bone so we could fix it with a splint. But maybe the future of healing isn't about fixing what's broken from the outside. Maybe it's about looking into the complex, sometimes murky waters of our own biology and realizing we already hold the exact blueprint to rebuild from within.
It's a fascinating future to watch unfold.
It really is. Thanks for taking the deep dive with us. We'll see you next time.